Let me just say good morning, everyone. I now call this joint meeting of the Human Services and Insurance Committees to order. Thank you all for being here. Today we want to focus on the critical services and supports available to Pennsylvanians living with traumatic brain injuries. Sign-in sheets are available for the Human Services and Insurance Committees, and before leaving, please make sure that you've signed the sheet for your respective committee if you haven't already done so. Today's meeting is going to feature 3 panels. Each panelist will have up to 5 minutes to present, followed by a designated Q&A session. Members wishing to ask a question should notify the executive directors to ensure that we stay on schedule and hear from everyone. I'm asking that our committee members please truncate their questions, make them concise, and simply refrain from general commentary. Please note that with other committee meetings taking place concurrently, there will be some members who need to step in and step out. And to our panelists, your written remarks have already been shared with committee members, and so I'd like to just encourage you to use your time today to highlight the key points, share the additional insights, and engage in a more conversational dialogue, please. And once again, thank you all for joining us this morning. Now, before we begin, I'd like to invite my colleagues to share any brief comments they may have, and so I'm going to ask Chair Heffley. He'll be followed by Chair Warren, who'll be followed by Chair Pickett. Gentlemen, please.
Thank you, Chair Williams. And I want to say good morning to my fellow chairs, Warren and Pickett and Williams, and as well as all the members of the Human Services and Insurance Committee. It's a really important meeting that we have here on traumatic brain injury. According to the Brain Injury Association, there is about 138,000 brain injuries sustained by adults and children each year in Pennsylvania. Just last year, there were 543,288 Pennsylvanians were living with brain injuries and disabilities. No two brain injuries are the same and require a complex level of care. That's why this conversation is so important. I recently worked with one of my constituents with a brain injury who was facing termination of his medical assistance coverage. This was particularly challenging when he had surgery scheduled only days later. I'm happy to report that he was able to, his insurance wasn't terminated, Medicaid, and he was able to get the procedure done. But it's opportunities like that we look to address and try to alleviate some of those issues moving forward. So I thank you to all the presenters as we have this discussion going forward. Thank you.
Thank you, Chairman. I'm Perry Warren, Democratic Chair of the House Insurance Committee. Thank you to all of the testifiers for coming to Harrisburg bright and early this morning, and especially to the staffs of both the House Human Services Committee and the House Insurance Committee for putting together this meeting for our first full session week of the year here so that we can attack this critical issue of brain injury treatment and brain injury services and brain injury funding. At the very start of the session, it recognizes the importance of your services to our communities, to your clients, to our patients, and gives us a full 2 years to move the ball forward in working with the brain injury community. So thank you.
And thank you, Mr. Chairman. We all know when a brain injury occurs, it's usually sudden and very unexpected. The recovery time is long, requires highly specialized services. Emotional and financial costs are enormous. I've personally felt this with several of my own constituents as they try to work their way through such a situation. From an insurance perspective, I'll be interested to hear how auto and medical policies cover the critical services these patients need. Thank you.
I appreciate that. And so let's begin with our first panel. I'd like to introduce Ms. Julia Marsala, Deputy Secretary of the Department of Human Services, Office of Long-Term Living, Dr. Drew Nagel, Brain Injury Association of Pennsylvania. Please join us at the table. And who wants to go first? Thank you so much.
Good morning, Chair Heffley, Chairman Williams, Chairman Warren, and Chairwoman Pickett. I'm Juliet Marcella. I serve as the Deputy Secretary for the Office of Long-Term Living, and it's my great pleasure and honor to serve Pennsylvanians in this role, particularly focused on providing services to older adults and people with disabilities. We have a really difficult time sharing all of our critical services in a short 5 minutes, but I will certainly give it a go. And I will focus on brain injury in particular, services and community health choices, our largest managed long-term services and supports program that serves over 4,000 Pennsylvanians. Within that program, we serve both individuals who are what we consider healthy dual eligible individuals that do not meet the nursing facility level of care criteria. We also serve over 130,000 people who do meet a nursing facility clinical eligibility level of care. And that's important because those individuals are the individuals that are eligible to receive long-term services and supports. Services and supports that are critical to help them live independently in their communities of choice. And now within that group, we have 33 services that individuals can choose from if they meet the needs for them to help them build out their person-centered plan, to help them live independently in the community. And we're really proud of Community Health Choices being able to provide all of those 33 services because prior to Community Health Choices, people with brain injuries, non-traumatic brain injuries, didn't necessarily have access to all 33 services. And when we pulled the prior waivers in, including the waiver specific to traumatic brain injuries, we pulled in every service within that traumatic brain injury waiver into Community Health Choices. So people with a brain injury, be it acquired, organic, or traumatic, could receive any of those 33 services. So we broadened and made it easier for folks to access services without having to be in this waiver or that waiver or that waiver. Within Community Health Choices, in the long-term services and supports, we serve approximately 1,600 individuals with brain injuries who meet the criteria for nursing facility or higher care. Those individuals choose a variety of services. There are 90% of the individuals that we serve with brain injury choose personal assistant services, transportation, therapies to help them live in their own communities, in their own homes. We also have some services that you may hear about today called residential habilitation services, where individuals get supports and live in sort of group home settings of 8 persons or less or 4 persons or less. There are approximately 500 individuals in 2023 who chose that setting. In 2024, that number's come down a little bit to a little over 400 individuals have chosen to receive services in those settings. In addition, we also provide cognitive rehab therapy. It's a very important service to our brain injury community. We are excited to say we've expanded access to community cognitive rehab services in partnership with our associations and advocates by allowing that service to be provided through teleservices. It was ordinarily done in person, and so we've allowed the teleservices option that was just approved in effect January of this year. In those services, there are approximately 550 individuals who access that service. And what's important to know about cognitive rehab therapy is that there's a requirement for third-party liability in that individuals must use any other insurance coverage or third-party liable payer, such as an accident insurance, long-term insurance, things of that nature, before they can access those services under the Medicaid program. And so cognitive rehab therapy is also available under Medicare services, and 90% of our individuals we serve have both Medicare and Medicaid. So that would mean for them that they would have to access and exhaust the Medicare allowable services prior to receiving them in the waiver services. That's a federal regulation. So I just wanted to point that out. And lastly, we also have numerous individuals, about 530 individuals who rely heavily on community integration. These are services that allow people to learn or rehabilitate, to learn how to use transportation, how to do budgeting, how to plan for meals, how to engage again in social activities and get additional assistance in training and support to do all the activities that they want to do to reach their goals. So we wanted to kind of share those importance and those critical services, and I know I have 5 minutes, and I've probably already gone over. We value our partners and our advocates. We build a lot upon their comments and their public comment periods as we renew or revise the waiver programs and standards. And so I think, what's important here is to remember that these services are very critical to allow people to be independent, to choose their services, and to remain with their families of choice, work in our communities, live in our communities, and live the most fulfilling lives that they can. And I am happy to answer any questions.
Deputy Secretary, thank you so much. Dr. Nagel.
Thank you, Chairs Williams, Warren, Heffley, and Pickett for this opportunity. I am Dr. Drew Nagel. I'm trained as a neuropsychologist, board certified in rehabilitation psychology, and I'm a certified brain injury specialist in advanced practice. I was the founding president of the Brain Injury Association of Pennsylvania, and today I am the co-chair of their advocacy committee, which is the Pennsylvania Brain Injury Coalition. The Brain Injury Association, as Chair Heffley pointed out, represents the over 500,000 Pennsylvanians living with acquired brain injury. And those who survive a brain injury face a wide range of challenges, cognitive, behavioral, and emotional difficulties, which, if left untreated, can result in life-altering severe disability. It is, I appreciate the services that Deputy Secretary Marsala points out that CHC provides. They are a lifeline for those with the most severe disabilities who can qualify for medical assistance. But the great majority of Pennsylvanians don't qualify for medical assistance. So I'd like to address some of their needs as well today. An acquired brain injury is an insult to the brain, either from an external or an internal cause, not hereditary, not congenital, not degenerative, or the result of birth trauma. It can be caused by external force, like in a car accident, a fall, a sports injury, or it could be caused by a stroke, an infection, a lack of oxygen, say from an unintentional opioid overdose, a tumor, or seizures. The important thing to take away here is that once brain cells are injured from any of those causes, they don't grow back like skin or bone or muscle cells do. They are forever lost, and that injury results in changes in how a person can think, and it affects their everyday life skills. The most common effects on thinking are impairments to memory, problem solving, reasoning, judgment, and this often makes it difficult for people to go back to school or work or even take care of themselves at home and in the community. But even though this injury to the brain is permanent, there are rehabilitation treatments that are available to help people learn different ways to think and act and improve their functioning in everyday life. However, because of the way our healthcare system is structured, these rehab treatments are not available to everyone at the time they're needed. People who have brain injury are frequently unable to access the evidence-based post-acute neurorehab treatments that are necessary to continue their rehabilitation process after hospitalization. And my colleague just showed me a whole issue of the Journal of Head Trauma Rehabilitation just published that addresses this very issue of what happens to people after they come out of the hospital. Without access to these treatments, long-term disability increases, putting extra burden on the state to provide long-term services and supports. A recent Brandeis University study shows that the state could save an average of $1.5 million per person on long-term services and supports if appropriate access is given to care early when needed. I mentioned that I co-chair the Pennsylvania Brain Injury Coalition, which supports and advises the Pennsylvania Brain Injury Legislative Caucuses, co-chaired in the House by Chairman Briggs and Flood, and in the Senate by Senators Farry and Carney. They have introduced legislation that will assure access to the right service at the right time for those covered by commercial health insurance, which will decrease the burden on the state to provide costly long-term services and supports. Studies show that the outcomes after brain injury can be improved with appropriate and timely post-acute neurorehab treatment. Without that timely and appropriate treatment, increased costs to government show up in other forms, such as unemployment, increased disability income expense, increased health care expense, including psychiatric treatment and substance misuse treatment. And in the worst case scenario, the costs show up in domestic violence, homelessness, and criminal offending. Other important legislation that's being proposed in this 25-26 session include a bill that will ensure a budget line item funding for core brain injury supports, such as information and referral, support groups, brain injury education and training, the State Advisory Council on Brain Injury, Brain Steps School Reentry Program, and neuroresource facilitation. Another important proposal will provide parity for brain injury residential providers who have not received rate increases since 2012, while autism and intellectual disability providers have received increases in their rates. The network of experienced brain injury providers is essential, and we support the RCPA request for $13 million in state funds to bring these providers up to the level of parity with other similar providers for people who have disabilities. And the Brain Injury Caucus is also planning to introduce legislation that will amend the Safety and Youth Sports Act to include non-scholastic league and recreational sports, and to provide information on the state's Return to Learn program, Brain Steps. So the Brain Injury Association of Pennsylvania looks forward to working together with legislators and state agencies to improve access to brain injury rehabilitation so that people can get the right care at the right time and get back to living productive and fulfilling lives. Thank you, Chairman.
Thank you both for your presentations. Right now, I want to open up an opportunity for many of the members here to raise questions.
Yeah, thank you both for your testimony. You had mentioned if you get treatment right away, you're going to save roughly $1.5 million. So using that as sort of a backdrop, what is the average cost of, if there is such a thing, of treating a brain injury?
It's a good question. The effects of brain injury vary so widely from mild brain injury to moderate to severe brain injury that it's hard to state average costs. But I know that there was a comment earlier about, I think it was Chair Pickett that talked about the, are the costs paid by auto insurance if it's a car accident? Are the costs paid by commercial health insurance if a person's working and they're paying premiums for that? And the answer is that usually the initial injury is paid for as through the hospitalization, either by the person's commercial health insurance or Medicaid or Medicare. The auto insurance has just about evaporated as a payer because the minimum first-party medical benefit required in Pennsylvania is now $5,000. That goes, you know, the helicopter ride to the hospital costs more than that. So that goes right away, and then we're reliant on the health insurance system. It's after the person leaves the hospital where the holes start to appear, because the average commercial health insurance policy pays for 20 to 30 visits of outpatient treatment, and that can be used up in a matter of weeks or a month. And then the person has nothing. And if they don't qualify for the Community Health Choices waiver, which they may not because they have income and assets, then they're left to their own devices.
Representative Kincaid.
Thank you, Mr. Chairman. So you alluded to this, but I want to just ask it explicitly. Have you observed an increase in acquired brain injury as a result of opioid overdoses?
Yes, we have. In fact, the Brain Injury Association of Pennsylvania is under contract with the Pennsylvania Department of Health to provide education and training to substance misuse providers because of this uptick in anoxic brain injury that we are seeing related to the opioid epidemic.
So I think it's important, in your testimony you said, and I think it's important to reiterate, that brain injuries occur indiscriminate of age, gender, socioeconomic level, ethnicity, sexual preference, and affect everybody, including families, employers, and the entire community. They impact memory, problem-solving, reasoning, and judgment, which in your testimony you said makes it hard for them to go back to school, work, or get, or even take care of themselves. What we have increasingly recognized, what it also does is increases, and you said this a little bit later, the likelihood of somebody interacting with the criminal justice system. So I'm wondering, and I guess this is a sort of a question for both of you, is how are you guys working with the Department of Corrections to ensure that brain injuries are treated as medical issues, as treated appropriately in that way? Because frequently what we see in the Department of Corrections is people who have disabilities it takes them a little bit longer to process when orders are given, and they don't necessarily react as quickly as they're expected to. They don't necessarily react in the way that they're expected to, and it often leads to things like disciplinary action. How are you guys working with the Department of Corrections to ensure that Pennsylvanians who are unfortunately at that intersection are treated appropriately?
So one of my other roles with the Brain Injury Association is I'm co-investigator on a federal grant funded by the National Institute of Justice, exploring just those issues in Pennsylvania prisons. So we're working very closely with DOC. We are in 4 Pennsylvania prisons screening for the evidence of a lifetime history of brain injury. And once we identify an inmate as having that history, connecting them through neuro-resource facilitation to resources like Community Health Choices when they leave prison, and other resources. So the results of this 5-year study are just now being analyzed. But I'm happy to say that the Department of Corrections is working with us to establish a culture of neuro-informed care throughout all Pennsylvania prisons, and we're implementing that with education and training over the next year.
Thank you.
Thank you. There's a question by Representative Flood.
Oh, I think maybe Deputy Secretary had something
Oh, I'm
to say.
sorry.
Thank you. To answer your question from the perspective of the Office of Long-Term Living, because community health choices services start within the community, there is limited amount of impact that we can have sort of behind the walls before someone re-enters into the community. We do have complex case management group that does work very closely with the Department of Corrections to help build the plan as best we can for when individuals do transition back into the community, particularly if we know in advance they need long-term services and supports, and meet the clinical eligibility and help them through that application process. We are hopeful with the work with the 1115 waiver that opens more doors for us to work with individuals with traumatic brain injuries in the reentry population earlier, so we can have stronger plans and stronger services in place to really help successful transition back into the community as they reenter and regain their lives.
Thank you. Thank you, Chairman.
Thank you. I know that Representative Flood has a question, and again, members, would you truncate your questions so that we can keep moving towards the next panel, please? Representative Flood.
Thank you, Chairman. My question is directed towards the residential habilitation programs that you have, or also known as ResHabs. What are some of the constraints for allowing people to enter those programs?
So under the community health choices, individuals undergo a comprehensive assessment, and they have to meet the needs for each of the services that is provided. And then they're allowed sort of a preference how to address those needs. So individuals who are interested in residential habilitation, they pay the room and board portion of residential habilitation, because under the Medicaid program, we cannot cover room and board. So there's a contribution of a percentage of their income that goes to the room and board of the residential habilitation provider. They have to sort of want to participate in that structured program. It's a very structured program. And then there needs to be network adequacy of providers who are willing to take that individual as well. So it's not just the choice of the person, but also a choice of a willing and able provider to meet their needs.
So is it fair to say that there might be a limited opportunity for people who want to participate in a ResHab program to be able to get into that? Is there a wait list for that?
OLTL does not have a waiting list for residential habilitation services at this time. We understand, and you've heard from testimony, that there's rate disparity that puts pressure on that network, with more residential habilitation providers maybe being more available in the ODP service versus the OLTL service. But there are distinct differences between that rate and that rate setting process. In the Office of Developmental Programs, they do subsidize some of the room and board with state dollars as a result of savings from closing institutions. OLTL does not have access to that kind of appropriation because we can't use Medicaid dollars to subsidize that. So oftentimes when folks look at the rates, they also kind of include that in that disparity discussion. Where we can and when we can, we try and support our residential habilitation providers. In 2021, as a part of ARPA funding, we were able to increase rates by 3% by including a vacancy factor into our assumptions for residential habilitation rates and for the providers. When the CARES Act, we were able to provide an additional $525,000 directed to our residential habilitation providers to help support them with investments in direct care workers, which are very critical to the residential habilitation providers, and also to help support their meeting the what we call the HCBS final settings rule. Our residential habilitation providers have to meet federal guidelines that indicate they are indeed community settings. And we've done a lot of work with our provider partners to help them meet that level of community setting, which had required some changes in how they do their work. And over the years, it also has had some providers decide no longer to be residential habilitation providers. We watch network adequacy very closely. We would love to have expanded residential habilitation providers serving not only individuals with traumatic brain injury, but individuals with any brain injury, and even further, any individual who may meet a residential habilitation need. So very much interested in seeing growth and availability.
Members, in the interest of time, I'm going to ask you if you would, we'll make that the last question. Feel free, please, members of the committees, submit your questions in writing to Imogen, and we'll make sure that we get answers as quickly as we can. Dr. Nagel, you look like you're anxious to respond.
If I could just add to for Representative Flood's question briefly.
Yes.
Yes. Thank you. The residential habilitation providers who have training and experience in serving people who have brain injury, which requires special CARF accreditation and so forth, are very few in this state. 14, I think, at last count. It used to be 15. I used to work for one who went out of business because they couldn't make the rates work, which the rates haven't been increased really since 2012. The rate increase that Deputy Secretary mentioned wasn't really guaranteed to be passed through to the providers in a way that could help them to hire qualified workforce. After the pandemic, the rate that we have to pay for qualified workers has gone way up. It used to be like $11 or $12, and now you have to pay $19 or $20 to get qualified people because they can go to Amazon and earn that much. We're talking about people who are very dedicated to their work, and it's not easy work working with people who might be emotionally or behaviorally combative, and so it's very important that we address this rate issue and make sure that more providers don't go out of business, which will create an artificial wait list for those wanting that service.
Listen, thank you very much for your insights and your testimony today. Deputy Secretary Marsala, Dr. Nagel, thank you so much. We're going to ask our second panel if they'll make their way to the table now. I'd like to invite to the panel Dr. Tim Law, Chief Medical Officer for Highmark, Mr. Jonathan Greer, President of the Insurance Federation of Pennsylvania.
Hello, I'm virtual. Can you hear me okay?
We can hear you.
Thank you. Members of the House Insurance Committee and House Human Service Committee, thank you for inviting Highmark to discuss traumatic brain injury today and what our comprehensive approach to coverage for services related to this complex condition are. I won't go over the specifics of TBIs. That's already been mentioned. I will say that I have a personal interest in this, as in 2011, I had a daughter that was in a motor vehicle accident, was in a coma for nearly 2 months. And so my journey through the coverage of the insurance that I had at the time was long and arduous, and glad to say that she's still with us today, although not the same person, and certainly under the tutelage of her mother and I at home to help her get through every day, but still a productive member of society. So all those neuro rehab people out there, we thank you all. Highmark recognizes this complexity and the long-term implications of TBIs. Our commitment to providing the comprehensive coverage is reflected in our medical policies. I've listed some in the document we sent. We have cognitive rehab, physical medicine, speech therapy, occupational therapy, which have been mentioned already. To one of the questions earlier, yes, it's you can use up to 20 or 30 that's in the benefit brochure very quickly with this. We have come up with something a little different that I think is now being adopted across the industry, and that is having something called a flexible benefit. So say you have 30 visits in your benefit brochure for physical medicine, 30 for speech, and 30 for occupational therapy. Maybe you only need 10 visits for speech, and so you have these 90 visits total in there. If you've used up your physical or occupational therapy visits at 30, we have a way in some of our lines of business where they can flex those unused benefits from the other therapies over to that, so giving you possibility of 90 visits in the physical therapy realm or the occupational therapy. We don't have the limits on the cognitive rehab because that is not something you can delineate by a number to come out on the other end. So it's just a unique way to cover it, I think. Our provider partners, members, general public, we have a very transparent and open policy system, so they can all look into those and see the specifics of the policies on our hyperlinks on our website, which is available to providers as well as the general public without any sort of password or domain issues. Our comprehensive coverage includes, of course, all the diagnostic imaging, as has been mentioned, is so important in the early process of diagnosis, CTs, MRIs. There's some SCAT and some other concussion protocols that are looked at too, and those can be seen there also. Beyond coverage policies, as you know, Highmark is an integrated health system, which includes Allegheny Health Network here in the Pittsburgh area, who delivers high-quality TBI care. They operate a 17-bed inpatient rehab facility in Natrona Heights. It's equipped with state-of-the-art technology there. Things like some of the things that have BioNest integrated therapy system. That's a system that provides an interactive therapy which looks at visual motor skills, cognitive function, endurance. One of the things that's so important to these patients is knowing if they are able to drive again to function in society. And so they have a device called a Drivable, which is the assessment tool, helps determine a patient's readiness to return to driving. I've seen it. My daughter has used it. It's like a car cut in half, and it has the ability to get in, simulated driving, make sure you can put your seatbelt on, close the door. You got all the things that you don't think about when you're walking into your car. It has them go through that in a repetitive fashion to make sure that it becomes a part of their makeup and their brain again. Virtual reality systems. We have VR technology assist in improving balance, range of motion. We even have one that is new on the market that you wear this VR headset. You watch about 20 minutes of SpongeBob or the cartoon of your choice, and helps fix lazy eye and bring it back into into focus, so you don't have to wear a patch over your eye throughout the day. It's pretty nice technology. Beyond the Natrona Heights facility, AHN also offers a lot of outpatient rehab services at a lot of locations, including across Pittsburgh, Forbes, West Penn, Canonsburg, St. Vincent Hospital, Jefferson. The extensive network, ensures accessibility to these crucial care for individual TBIs. We've heard there's not many rehab facilities across the state. We sometimes have people that have to leave the state to get a bed and that kind of thing. So anyway, Highmark is dedicated to providing that coverage and access to whatever leading edge treatment is out there. We have a new technology and assessment committee which looks at these technologies on a monthly basis. We have a meeting today to look at 3 new technologies in that field. We believe that coordinated, this multidisciplinary approach to care, fostering the best possible outcomes for our members, and we are continuously evaluating and improving those services to meet these evolving needs of those affected by this, which is a significant health challenge. Anyway, happy to answer questions after the next panelist, and thank you for your time and consideration.
Dr. Law, thank you. Mr. Jonathan Greer.
Excuse me. Thank you for the opportunity to come up before you today. My name is Jonathan Greer. I am president and CEO of the Insurance Federation of Pennsylvania, which is a state trade insurance association. Our membership includes commercial health insurers, auto insurers, and workers' comp insurers. And the breadth and the diversity of our membership gives us a unique perspective to the issue before us today. In the interest of time, we do speak upon the health insurance element. I think Dr. Law covered it well, so I don't need to rephrase what he has already covered, although I'll be happy to answer any questions. I do want to touch upon the interplay of 2 other forms of insurance that will come into play in a situation like this, and Chair Pickett, you kind of referenced it. Auto insurance, and one that was not mentioned is workers' comp insurance for a workplace injury. So a traumatic brain injury, and let me start at the beginning. When we think of a traumatic brain injury, we feel that it is a result of a trauma, an external trauma. When we think of an acquired brain injury, we think of a stroke or something like that. So that our understanding is when you speak to a traumatic brain injury, that's from an external force, whether it be someone hitting you over the head with a baseball bat, or if you're in a car accident. When we think of an acquired, we think of it as something that happened as a result of a stroke or something along those lines. So that's a distinction that we have. It was mentioned earlier that medical in auto insurance is relatively, first-party medical is low. That is true. $5,000 is the minimum, and it is a required benefit. That does not mean that $5,000 is what everyone has. I suspect many people in this room have more than the auto minimum that is required. That said, whatever it is, given the nature and severity of a traumatic brain injury, it is true that that benefit will likely be exhausted relatively quickly. And when that happens, then we get into things like coordination of benefits and subrogation. So, for example, if my traumatic brain injury in an auto insurance setting is caused by someone else, a third party, a drunk driver, my insurer will subrogate against the other driver's insurer for some of those costs. So the first-party medical benefit, yes, it is relatively low, but that is not the only source of money that may be available to access for the treatment of a traumatic brain injury. That's one very important distinction. The other is that, and I think this was mentioned by the earlier panel, it is true that the health insurer will likely be charged initially for the care associated with someone in an auto accident. However, that health insurer will understandably seek recoupment from the auto insurer for the amount that's covered under the benefit. And it may also seek subrogation against the third-party tortfeasor that caused the accident in the event that happened. It does get complicated when you're talking about different policies and coordination of benefits and subrogation, but typically that is how it works. It gets a little more complicated, a little more complicated in the workers' comp setting. So in a traumatic brain injury that occurs in the workplace will be covered by workers' compensation, which, like auto insurance, is required and importantly, does not entail any cost sharing. So there's no copayment, there's no deductible, it's first dollar coverage. Under the Workers' Comp Act, and that's true here and it's true throughout the country, and an injured worker is unable to sue their employee for the workplace injury. In return, there's workers' compensation insurance, which provides both medical and indemnity benefits. That's what's commonly referred to as the grand bargain in workers' compensation. However, and we talked about the third party in the auto setting, if a traumatic brain injury in the workplace is caused by a third party, and this would be, for example, the manufacturer of a piece of machinery that has a design defect. In that case, the injured worker, they can't sue their employer, but they can sue that third party for damages. And that's standard practice here and throughout the country. And that's ultimately that the proceeds of that settlement can be used to help defray the cost of the claim by the workers' comp insurer. This idea of subrogation is common and has been common in Pennsylvania for over 100 years. The Comp Act allowed for subrogation against these third-party settlements for both medical and indemnity benefits for that third-party settlement and it makes perfect sense. Absent that, the workers' comp insurer is responsible for a claim that it's not responsible for by virtue of there being a third-party settlement. It makes perfect sense to do that. Unfortunately, in 2018, the Pennsylvania Supreme Court, in a case called Whitmore v. Workers' Comp Appeals Board, said we are not allowed to make subrogation for future medical benefits because of a technical reading of the Comp Act that says those benefits are not paid in installments. And the Act speaks to installments. So yes, indemnity benefits are made in installments. We can subrogate against that third-party settlement for future indemnity, but we are unable to do it for future medical because it violates, according to the court, the installment standard in the Act. We refer to that as the Whitmore decision. It is unique to Pennsylvania. There is one other state that does not allow it. 48 other states do. There is a legislative correction to that decision that we've introduced since 2018, which is when the decision was made. And I would be remiss if I didn't use this as an opportunity to elicit your support of that correction. And we expect to have a bill introduced to that effect here shortly in both chambers. So in the interest of time, that's a truncated version of my testimony, but I would be happy to answer any questions.
I appreciate that. Questions from members?
Getting back to that legislation, what's the reasoning why it hasn't moved forward? I mean, you have, it seems like that would be bipartisan in nature, and I just am kind of curious.
Our friends in the plaintiffs' bar will feel differently than that. And it has been perceived, I think, incorrectly and unfairly as an anti-worker piece of legislation. And it's not. If it was anti-worker, it would have taken 100+ years for this to happen. It is standard fare in workers' comp that this is how it works here and everywhere else, except for the state of Georgia. I don't know why Georgia's different, but we have tried. It did pass the Senate, and we've been unable to get it through the House.
Yeah, I just was kind of curious. And if you just one real quick question: rehabilitation and physical therapy. I know I have people that they're seeking help and everything like that. Will insurance cover that, or how, and for how long?
I may defer to Dr. Law on this question, but before I do, there are two broad buckets. It's rehabilitative care and habilitative care. Rehabilitative care is to try to regain some of the function that you lost. Habilitative care is to maintain that which you've been able to regain. Those right. Those two kind of work together. Dr. Law, I don't mean to go ahead if you have anything more to add to that.
No, yeah, you've hit it on the head there. That's correct.
Yeah.
Representative, please go ahead, ask your question.
Thank you, Mr. Chairman. An intended short question. Hopefully, I think you can provide a relatively concise response. I was just wondering about trends with brain injuries. Do you see that these are occurring more with children or with adults? I know it can happen at any time for a variety of reasons, but I was just wondering if there was a trend.
That's a great question. I don't know the answer to that. The one thing that, and we opposed it at the time, and I don't think I was here, many of you were not probably, but Representative Pickett probably was, when we repealed the helmet law for motorcyclists. I don't know what the data is since that time, but it would stand to reason that there are more traumatic brain injuries as a result of that repeal than there were before. I don't have that data.
You know, we've done some tracking and trending at Highmark, and the only trend that we saw that was a overall reduction in brain injuries during the pandemic, the height of the pandemic, which may have been attributed just people staying home more, I'm not sure. But as far as the MBA type trauma brain injuries, those went down, but not in any one age group. It was across the board. But we have seen no other trends, elevated for, age group, et cetera.
Thank you very much.
Representative Schlegel, thank you. Are there any other questions? Representative Nelson?
Thank you, Imogen. Thank you, Mr. Chair. A question following up on the opioid aspect of brain injury. Insurance treatments for people who are trying to work through in recovery, would those fall into the habilitation side or the rehabilitation side? Are those reversible, the damage that's caused or the trend that's finding? How does that work moving forward?
Well, you're talking, and now again, Dr. Law, he's probably forgotten more about this than I know, but you're talking about two different related issues, which is substance abuse, and then the treatment for someone who was an addict, who had what I think would be an acquired brain injury as a result of that, and how that works. I was interested to hear the flexible benefit idea that Dr. Law spoke to, because that is very reminiscent of what our substance abuse mandate provides in terms of inpatient versus outpatient, and then you can exchange one for the other. So, Dr. Law, I don't know if you want to speak to that or not.
Yeah, I think it's a combination of the two, depending on where they are in their rehab of the addiction part of it. So there's some rehabilitative part of that, but it can move to the habilitative service, and that's why I think this flexible part about going back and forth, depending, the life of an addict is not finite as far as you're one and done kind of thing, and so they often oscillate between the two types of therapy.
Yeah. Okay. Thank you, Mr. Chair.
Thank you, Chairman Heffley.
Thank you, Jonathan, for being here. Just the interaction, if there's an auto accident, and how auto policies and health insurance policies interact and cross over. I mean, you're looking at a traumatic brain injury, you're looking at years, lifetime of care and need, and also in rehabilitation. It takes a long time for the brain to heal. 90 visits or what? I mean, you're looking at years, decades. How does the auto policy, and a lot of times there's settlements, as you talked about, that money has to be put aside for some of those costs.
Yeah.
Correct.
Yep.
So if you get a big settlement, but you're still that money's going to go to pay part of that care and that.
And that's part of those costs were presumably built into what the settlement was too. That was kind of a factor of why you came to that number. Yeah.
And eventually many folks then would wind up on MA, right, medical assistance, because unable to work. And
it's difficult to speak generally because every case is different. and you have the interplay of different kinds of coverage, whether it be health insurance, workers' comp, auto, Medicaid, Medicare, the traumatic brain injury program. There's a lot of coordination of care, and I think that's why the term earlier was mentioned, case management, because every case has got to be managed based upon the severity of the injury, the setting in which it occurred, the insurance that's implicated. It gets really complicated really quickly, and that's why I think when you speak to case management, that's the very individualized approach. It's going to be different for every single case. It's going to be different for all those reasons.
Just a point of clarification, those 90 visits per year, that's per year, not per life of the injury. Just so those get used up, but then in the new year in the insurance, in the medical insurance side, that renews at the beginning of the plan year.
So just the follow-up, obviously under the Affordable Care Act, somebody would be covered till they're 26 years old. So somebody's on their parents' insurance or involved in an auto accident, and they have, maybe a decent health insurance through their employer. When they turn 26, they lose that coverage under their parent if they are not capable of retaining coverage, and they would probably go into like a MA and then transition.
Well,
into that.
essentially, and Dr. Law again, please. Both rehabilitative and habilitative care are deemed essential health benefits under the Affordable Care Act. So that's essential. Every policy has to include that. Now, so whether it be the dependent coverage up to age 26 or once that person ages out of their parent's policy, assuming they have an ACA compliant policy, it will include both elements that are deemed essential. So that now, if the person is in an auto accident, whatever the limits are, if it's a serious injury, those limits will be exhausted at some point, probably sooner rather than later. It is at that point that then, and typically what will happen is the auto insurer will write a check to the health insurer for the policy limits and say, okay, that's the extent of the coverage. That's how it's going to work.
Right.
And to your point, once they age out at 26, if they're unable to work and can't get a good commercial plan health insurance, then they're falling into some state or federal program, which may or may not have the same type of benefits as so plentiful on the commercial side. And I think that's probably where the gap exists, if there's any gap at all, for sure.
Thank you so much. Again, members, additional questions we can entertain, submit them please to Imogen in writing, and we'll make sure we follow up with responses. I'm going to make Representative Harris the last question, please, Representative Harris.
Yes, thank you, Chairman Williams. Just wanted to ask, with the increase in the medical costs, why hasn't the $5,000 medical cost hasn't increased with inflation?
It's a great question. You would get no objections to us on that in auto. The problem is when you open up what's known as Act 6, that's where all the other minimum, that's where that's found, 5,000 first-party medical. That's also where property damage, first-party property damage is third-party property damage. That's also where the third-party liability language is. And they've all been kind of stationary for years. When you open the Act, you open all those other forms of coverage to go up as well. And if you do that and you increase the auto minimums for liability, third-party liability, which are $15,000 and $30,000, 15 per 30 in the aggregate, you raise the prospect of raising the cost of auto insurance significantly, and particularly in a place like Philadelphia. And that's why it hasn't happened. Yeah.
Thank you so much, Dr. Law. Mr. Greer, thank you for your presentation today. I'm going to call our next panel to the table, please. Good morning. Good morning.
Hello.
Welcome, Dr. Richard Edley, President of RCPA, and welcome Ms. Joanne Tangney, President of Success Rehabilitation. Dr. Edley, please feel free to begin.
Okay, and again, echo what others have said. Thank you so much, chairs and committees, for having this important hearing today. I am Richard Edley, President and CEO of RCPA, and we represent over 400 agencies and organizations in health and human services throughout the Commonwealth, including, obviously, here today, Brain Injury Services. And I'm here just to be clear, there's a problem. And it's been going on for years without resolution, and that's the reason we're here. And when people with traumatic brain injury and serious needs can't get the services they need and are told, I'm sorry, we don't have those services. And I know you heard earlier, there's no wait list. I'll address that in a minute. We have a problem. So our request is very simple. As Dr. Nagel said earlier, we're looking for an infusion, an investment by the legislature of $13 million immediately to the residential habilitation providers of brain injury services. And you'll also hear in my testimony, you'll see it in my written testimony, well, there is no brain injury providers. So if you want to be technical about it, residential habilitation providers specializing in brain injury services, if that makes people happier. But it's the brain injury providers. They need the investment infusion of dollars. I'll also make the point that that comes with a $17 million federal match. So immediately that becomes a $30 million investment in these brain injury services. I also point out in my testimony, my written testimony, that there are other things we could do in terms of studies and longer term things, all critical, but the immediate financial investment is what's important. I also want to clarify, why is OLTL here today? Why is it involved with brain injury services? Because if you do the research, you'll see other states are not quite like that. This is a real anomaly, the way it's done here in Pennsylvania. The problem with that is you have billions and billions being spent through community health choices on things like nursing homes, on things like personal attendant services. Who's talking about brain injury services? That's why we're so appreciative of all of you here today. So at least before community health choices, there was something called the ComCare waiver, which specifically recognized brain injury providers. When community health choices came, those providers, that waiver went away, those providers were put under residential habilitation. They lost their identity. When Community Health Choices was announced in 2017, we immediately called a timeout and said to OLTL and DHS, we need to talk. Brain injury services are going to be lost. Again, you're going to have managed care companies coming in spending, depending on how you look at it, $8, $10, $14 billion, depending on how you slice it. Who's talking again about the 600 people in residential habilitation, the 1,600 people who are being treated in community health choices by the brain injury providers? What we argued is at that time, take these services and carve them out. Give them their own home or put them under the Office of Developmental Programs where there's like services. I'll get back to that as well. It fell on deaf ears. And here we are today, years later, talking about the same thing, that there's not been any significant increase and no one is listening. And you know, the bottom line is if you're not funded properly and you can't pay your staff properly, you have a problem. And then we all get up one day and go, wow, there have been program closures and agencies that have closed and resulting access to care issues, and we all look like we're stunned. Well, what'd you expect when you haven't funded it for 13 years and watched through COVID, through inflation, through all these things, and nothing has happened? In 2014, there were 18 brain injury providers across the Commonwealth. Today, there's 13, and 4 of those have either closed programs or refused to take Medicaid. And what we're talking about today are the most seriously and significantly disabled and people with brain injury who are serviced under Medicaid. Dr. Nagel also hit on this a little bit, but I want to make it clear again. If people don't receive services, their issues don't magically go away. They languish at home with families who are desperately trying to figure something out, or they end up inappropriately in nursing homes. And I've had a chance to meet with a number of you on this panel talking about my own personal experience, seeing people in nursing homes and wondering, how is that person there? Well, you find out that's because they're a young person with traumatic brain injury and there were no services, so there they are. Or they end up homeless, hospitalized in prisons, mental health settings. It's a horrible situation that we really shouldn't tolerate. Now, I wanted to get into a couple of what I call the fallacies and assertions that you'll hear. The first I mentioned, you'll hear, well, there really isn't anything such as a brain injury provider, and that's ridiculous. The fact that you have providers who lost their technical provider type when community health choices came, we all know who they are. They're people like Joanne Tagny, who's sitting right here with Success Rehab. They're a brain injury provider. If it makes you happier to call them residential habilitation providers of specialized brain injury services, we can do that. But to make it simple, we call them a brain injury provider. You'll hear that there's no wait list. That's also a little bit of an interesting argument. We calculated last summer that there were about 300 people waiting for services at the agencies that RCPA represents. What does that mean? They've shown up and said, Here's my child, my son, whatever. I need an assessment. I need to get in. Ethically speaking, these agencies felt, well, we can't do that. Send them into the managed care companies, get them nursing home eligible, get them through the whole comprehensive assessment, as Deputy Secretary Marsala mentioned earlier, only to be referred back and say, by the way, we can't serve you. So what they've done is created their own list saying, when we're ready, we'll start the process. So technically, OLTL and the MCOs can say, there's no wait list. So again, if it makes people happier, we could say there's 300 people on the wait list for the wait list. I don't know what we gain by doing that, but we could say that. Or a wait list for an assessment list. But it's a wait list. It's people who aren't getting services. You'll also hear, well, isn't this just a negotiation between the providers and the MCOs? It goes back to my earlier comment. I wish we could get their attention. When they're spending and worried about billions of dollars, this is just an anomaly. This is just, I can't tell you how many meetings I've had with MCOs where they've looked at me and I could tell they're thinking, is this guy about brain injury here again? That's how they're looking at it. So until there's money available and OLTL is told, tell them to give it to them directly, nothing will happen. We're not getting their interest. Finally, you will hear, and you heard an allusion to it by the Deputy Secretary, that these providers really should be billing Medicare. I want to be clear. Residential habilitation is covered by Medicaid only. It is not a Medicare service, and that's the vast majority of the losses and the problems that we're talking about today. So, yes, speech therapy, physical therapy, occupational therapy, cognitive rehab therapy, many should be billed a small amount to Medicare, and they should do that. That's the law. But saying that that's the solution really deflects what the need is here in the state. The final thing I wanted to talk about, and because at RCPA we represent a number of different areas, we represent intellectual and developmental disabilities providers. So we've gone through that fight. And I would say that the advocates on that side of the fence honestly have done a better job. Legislators know what IDD stands for. They know what a DSP is. They understand that you need a living wage. Somehow in the argument, though, we're going to fund this. Well, not the brain injury people over there. If you look at the services, and you will also hear, well, it's apples and oranges. Trust me, it's apples and apples at the highest level. It's community group homes, it's DSPs, it's employment services, home and community-based services, transportation, being offered brain injury people. If you want to get down to it, and Dr. Nagel could give you the technical aspects of it, but what's the difference between the populations? IDD individuals were born with a cognitive deficit. If during childbirth you suffered a traumatic brain injury, you're now in that bucket over there because you have a traumatic brain injury and you're going to get less funding. And when we say that the critical need is 13 million, which becomes 30 million, that does not make these providers whole. So going back to the Deputy Secretary's comments that, well, there's differences in funding and there's some closures, and absolutely. We're not saying make them whole, give them 100%. We did the calculation. This gets them partway there, maybe 30, 35% of a help. But it's something. They need something to begin to keep these programs open. I'll stop at that point. Thank you.
I appreciate that. I was just getting ready to ask you.
I was getting on a roll, though. All right.
Well, we know. I'm going to ask Ms. Tangney, if you would please, President of
Richard
Success.
was doing so well, I'm not sure I can even follow that, to be honest with you.
Well, you have the microphone now.
I do, don't I? Absolutely. So, but thank you, Chairs William, Heffley, Warren, and Pickett for the opportunity to speak today. Joanne Tagney, President and CEO of Success Rehabilitation. Given the expert testimony of both Dr. Nagel and Dr. Edley, I don't feel the need to go into the etiologies, sequela of a brain injury, and or to discuss more the macro providers in the state of Pennsylvania. I really would just like to focus on Success Rehabilitation, and as a rehab program that opened in 1990, I have personally lived through 35 years of government changes, agency changes, and a devastating pandemic. The challenges of owning a business as a human service provider is quite different than any other type of typical business. If you're Walmart and you get your televisions from Samsung to sell and the price goes up, what do? You pass it on to the consumer. If you're Dell Technologies and your manufacturing costs go up, what do you do for that next computer that maybe Richard wants to buy? Again, the prices go up, they're passed on to the consumer. However, if you own a business in the human service field and a majority of your revenue is from the state of Pennsylvania, specifically DHS and some from DOH, for the purpose of total care and rehabilitation of your clients who have an acquired brain injury, what do you do to meet the demands of increasing cost? You rely on the wisdom of DHS and the Office of Long-Term Living and DOH to increase your rates commensurate with inflation. Unfortunately, the rate increases stopped in 2012. Success Rehabilitation and other brain injury providers are forced to operate our businesses with rates not adjusted for inflation or even given an annual COLA increase. We have approached OLTL on a consistent basis throughout the years and have attempted to work with many different administrations regarding the matter and the unsustainability of operating as a provider of brain injury services with rates from 2012. Obviously, we have not been very effective, and therefore we are very appreciative of the opportunity today to discuss our issues. In my written testimony, I pointed out 3 areas where, as a business, we struggle financially. The first one, workforce. Keeping up with DSP hourly rates offered by other human service agencies such as IDD and autism, and for most part even behavioral health, is very difficult. They can offer greater starting rates for their staff because they are funded primarily by ODP at a higher rate. Our hourly DSP rates are constantly evaluated and adjusted to meet our workforce demands. Additionally, at the same time, we have to evaluate for their supervisors, our managers, our clinical staff, our administrative staff, so you have an escalation that occurs. In 2020, we were all introduced to the new pandemic, COVID-19. Well, there are too many specific needs that healthcare organizations had to address. For the purpose of our hearing today, I'd like to continue to just focus on workforce. Prior to 2020, Success Rehab never had to need to work with agency staffing. We hired and retained our own workforce and were appropriately staffed, usually only needing our kind of internal, as you will, with 7 staff. That's all we ever needed. However, due to the staff fears of the pandemic, individuals chose to leave their healthcare careers. Hiring for a replacement has been a daunting task. Therefore, we had no choice but to work with agency staffing until we could increase the number of direct support professional staff. Success is still not at the level of DSPs, which are needed to care for our clients, and our dependency on agency staffing continues. In fact, in 2024 alone, Success spent $850,000 on this one line item, where prior to 2020, that wasn't even a line item in our internal budget. Benefits. Let's focus very quickly on medical benefits, because we also have the Insurance Committee here today. Since 2020, and I'm not going back to 2012, since 2020, our health care benefits have gone up 20%. We cover 85 to 90% of our employees' health care costs and strongly believe that it's the ethical thing to do. For the sake of time, I won't discuss the other benefits, such as short-term disability, long-term disability, and of course, we already heard the necessary workers' compensation coverage, which has also increased significantly over the years. So it's great to talk about the benefit, but the cost to the provider to have workers' comp is significant. In close, general expenses, and we all have them day to day. Recurring costs, food, utilities, housing, transportation, facilities management, to name a few, are significantly more expensive than they were in 2012. Yet we must find a way to pay our vendors their ongoing and ever-increasing rates with dollars not changed from 2012. On behalf of Success Rehab and the other brain injury providers in the state, I am asking for your assistance in reviewing the present rate structure and work with DHS to increase their rates until comprehensive studies can be instituted. So thank you very much.
Thank you both for your testimony. Again, members, I'm going to ask you if you would simply just compress your questions and be concise. Are there any questions for this panel? Representative Nelson.
Thank you, Mr. Chair. I appreciate the passion of your testimony. As we talk about the budgets and struggles with, the managed care organizations, community health choices, it's growing both in its cost and it's completely non-transparent. We aren't able to dig into that onion because everything is sealed to us as legislators. Last budget, there were dollars that were placed in this for this category, right? When you mentioned 13 million, a federal match of 17 million, so we would get more money if we invested it, but it didn't make it across the finish line. Was there a specific roadblock or, glitch from your perspective that, like, it was in there and then it was like Prego, then it wasn't in there,
But it's hard for me to know exactly why, but I could give you my feeling about it, my hypothesis. I think that the 13 and to 30 million, it's good and bad. The good is no one should ever make light of $1 million, but compared to billions, it's pretty small. What that also means, it's very easy to get lost. And so often when people are like, oh yeah, we'll get back to the 13 million, but what is this $2.4 billion thing? And so I think that's part of what happens. And then I think the second thing is those different fallacies that I brought up. I think it can get very confusing. That I bet I meet with some of you and explain what we need. Go, that makes sense. And then you meet with someone else. Well, there's really no brain injury provider per se. And you're like, really? Now we're off running down some other things. So I think trying to get clarity of the message and the request and following it through is important. That's just my sense of it. I mean, I would never know exactly what happened, but you're right. We've gotten close so many times only to find out it didn't make it.
And if I can, Mr. Chair, that if we're seeing community health choices and MCO costs to the state really increase, how is that not getting down into like the districts and the providers? Because their costs are to us have really increased, but it's not filtering through apparently.
Well, that's probably a question for the Deputy Secretary more than me. My assumption is it goes to those major categories again, personal attendant services and nursing homes, those areas. And I'm not saying they don't have needs. In fact, we have a division of personal attendant services, so it's not that I don't see their needs as well. We're just focusing on the one group that for whatever reason it hasn't filtered down to it at all.
Thank you, Mr. Chair.
Absolutely. Representative Harris.
Well, do you have any statistics on opioid use and aneurysms, and also the disruption of care in that field, in that avenue?
Yeah, that actually goes beyond my scope. Dr. Nagel, he's back there. I would assume the Brain Injury Association could certainly follow up with whatever data they have. That's more their purview, collecting some of the data on that. I'm more focused on the specific services and funding and so forth. But it's a great question that we should follow up on.
And if I may, I can tell you we have individuals in our program that are there because of anoxic brain injuries due to substance abuse overdoses. So it's definitely a need, again, depending on the acuity of the individual.
Just a reminder to the members of the committee, if there are additional questions that have not been asked and answered today, feel free to submit them in writing to Executive Director Wright, and we'll make sure we get those questions presented to you as quickly as we can. I'm going to ask now if Chairman Heffley, to be followed by Chair Warren, Chair Pickett, if they have any closing remarks. And I want to thank all of you for your presentations today and appreciate the time you spent here. Thank you so much.
Thank you.
Thank you, Chair Williams and Chair Pickett and Chair Warren for putting this meeting together. It is a very important issue. Individuals, anybody at any day could become a victim of a traumatic brain injury. It doesn't discriminate, and you don't see it coming, right? So whatever we can do to help get the services. If you've known somebody or experienced somebody, friend or family, with a traumatic brain injury, you can definitely see the improvement and how they can enhance their lives if given the opportunity to receive the right types of treatment. So I look forward to working together to ensure that anybody that's going through that in their life or family member is going to have that access, and whatever we can do to promote that and help that to happen. I think it's something that as a Commonwealth the people of the Commonwealth would expect of us. Thank you.
Thank you so much. Chair Warren.
Thank you all for bringing this issue of continuing care for brain injury patients to our attention, and to the insurers for describing the process through which different types of insurance carriers provide coverage for their brain injury clients. I look forward to continuing a conversation with all of the testifiers to try to, again, tackle the issue of brain injury funding and services in Pennsylvania over the coming term. Thank you.
Yes.
Yes, thank you. I, too, want to thank everybody who has been involved in bringing us together today on this subject. It was incredibly enlightening. We have work to do. I look forward to us working together to help this very important segment of our society. Thank you.
I think I want to echo the sentiments of the chairs who have already made comments. The insights, the expertise has deepened my own understanding of what I think is a very significant conversation that will be ongoing. And so to our panelists, I want to say thank you for your presentations. To the members, let me thank you for your participation in this informational meeting. I should say to you that it is one of two sessions that the Human Services Committee is holding to really learn in depth about how we can further improve the services for men and women who have survived brain injury. And so once again, thank you so much. Our next session will take place next Wednesday at 9 o'clock in this location. This meeting is adjourned. Thank you so much.